Welcome to Raaonline. So today we are going to see one of the very important trials, the TTM2 trial, that is Targeted Temperature Management 2 trial. So this is hypothermia versus normothermia after out of hospital cardiac arrest. So this was published in NEJM, New England Journal of Medicine in June 17, 2021. The clinical question being, in patients who are unconscious following out of hospital cardiac arrest, does targeted hypothermia compared with targeted normothermia impact the all-cause mortality? It means that should I really go for a hypothermic management or shall I maintain a normothermia in my patient who suffered a out-of-hospital cardiac arrest? So, why this question? The background being the HACA trial and the Bernard trial published in NEJM in 2002 reported that this therapeutic hypothermia following a VF arrest, ventricular fibrillation arrest, improved favorable neurological outcome. Okay, so this has shown some benefit, number one, but the sample size is very small. You have only 77 patients in Bernard's trial and only 137 patients in HACA trial, right? And the quality of evidence was also of lower certainty. A number of patients in the control group actually developed a fever, and it was therefore unclear if the reported benefits were because of your hypothermia in your intervention arm or it's because of your fever in the control arm, right? So your intervention need not be beneficial if your control team is not properly handled, right? So, and moreover, the TTM trial in 2013, the TTM1 trial, the Targeted Temperature Management 1 trial with a study population of around 950 patients, compared a targeted temperature of 33 degrees Celsius versus 36 degrees Celsius in patients with OOHC, that is out of hospital cardiac arrest, from a presumed cardiac cause alone. Okay, they did not differentiate between VF or VT or any other arrhythmic causes. This presumed cardiac cause. They reported no significant difference in all-cause mortality. So this was a negative study. The Hyperion trial, which had around 584 patients, showed that in patients with coma following a non-shockable cardiac arrest, the use of moderate hypothermia improved favorable neurological outcome at 90 days, okay, compared with a targeted normothermia. So here comes the normothermia versus hypothermia, but it's only non-shockable cardiac arrest patients and the follow-up time was only 90 days. So it is now unclear whether hypothermia or normothermia, which is better for your patients, number one, and how long you should actually follow up a patient. Should you follow up the patient only for 90 days or 180 days or till an year? So does the outcome really differ when you extend the course of your study? We really don't know. That is the course of the study. How long should the study be conducted? And second, what is the cause? What is the cause? Is it because only of presumed cardiac cause, or you can take it and generalize for a cardiac arrest because of any other causes? If it's going to be presumed cardiac cause alone, if it's going to be only a non-shockable rhythm or shockable rhythm also, we actually don't know. So this comes to a point where we question ourselves, really an hypothermia is essential or not as far as the neurological prognostication or mortality benefits is concerned in an out-of-hospital cardiac arrest patient. The European Resuscitation Council released new guidelines in March 2021, and they suggested maintaining a target temperature at a constant value between 32 to 36 degrees Celsius for at least 24 hours is essential. And also avoidance of fever, that is anything more than 37.7 degrees Celsius for at least 72 hours after ROC in patients who remain in coma stage. Okay, so this were the guidelines from European Resuscitation Council, because as we already know, fever is associated with worse outcomes. So now with this question in the background, we formulated a design, that is international multicentral parallel group trial. Okay, so when it's going to be an international multi-center design, the individual hospital biases or the protocol biases can be ruled out, and this is a randomized superiority trial. So what is the meaning of this kind of superiority trial? The meaning of superiority trial or inferiority trial is comparing one strategy with already available strategy to prove whether this particular strategy which you are going to invent has any superior benefits over the surviving strategy currently. So this is called a superiority strategy. For example, you are going to compare injection A with injection B, and you're going to prove that injection A is going to be better. You're going to check whether injection A is going to be better. So this is called a superiority trial, which is superior benefits compared to injection B, and you can do even subclass analysis. Moreover, with the same population only, there's co-enrollment with the TAME trial, that is targeted therapeutic mild hypercapnia trial. Okay. So randomization occurred in the emergency department itself. That's very early. So web-based allocation using permuted blocks of varying sizes in 1:1 ratio.